Okay. So welcome to imaging study. And today we are going to see 10 ultrasound cases, which will be, I think, helpful for your ultrasound practice. And these are from my regular practice. So sometimes you may get difficult cases, sometimes you may get easy cases. So usually we try to give you a demonstration about complicated cases. And sometimes we also want to give you idea about the common cases that we usually miss to diagnose. So anyway, for next few minutes, you hopefully will enjoy with me. So, Walaikum Assalam. I'm also connected to the live. And if you are connected from different ultrasound groups, I have posted same video in different groups. So if you are connected there, if you want to comment, try to comment on the live video so that I can answer it, because the live one is just got opened here beside me. So anyway, I'm Dr. Mahin Ashraf, and I'm from Bangladesh, and hopefully you will enjoy your next session. We have already uploaded our previous videos on our YouTube channel. If you are new to my this live session, I have a YouTube channel named Imaging Study, which is going to be getting 60K subscriber within a few days, I think. So if you're not connected to there, just try to subscribe our YouTube channel, and you will get, I think, a few ultrasound case videos there. Also, some previous live contents are present at that YouTube channel. So anyway, let's jump into our case number one, for which we are here. So this is, I think I have got 34% connected to my Facebook Live. So the number is very low. So if you think these videos are helpful for you, don't forget to share. That is what you can do for me. And together we can actually improve the education system, I think. So anyway, let's start with the case number one. So this is a 22-year-old female patient who came with an irregular menstruation, hirsutism, obesity, and infertility. I think with this history, you can just imagine what the case will be. So anyway, let's jump into the transvaginal ultrasound of this patient. So we have the transvaginal ultrasound, and you can see this is the uterus in longitudinal and transverse section. We just did the measurements, and it apparently looks normal. So let's go for the live session. So here you can see the uterus, you can see the endometrium. This is the fundus, this is the body, and this one is the cervix. So it apparently looks good. Now let's look at the transverse section. When we are at the transverse section, if you are doing transvaginal ultrasound, you know that the getting ovary on transvaginal ultrasound on first try is not quite easy. You need to search for the ovaries. But here, just after rotating the transducer, I can see both ovaries here. It indicates that the ovaries are quite enlarged. Otherwise, they won't come to you. You need to go to them. So these ovaries are quite enlarged. We'll go for the measurements. And you can see the stroma is quite echogenic. It's very prominent. And you can see these are tiny follicles within the ovary, which are more likely peripherally arranged, forming the pearl string appearance, which is a typical feature of polycystic ovaries. So these are the polycystic ovaries showing the pearl string appearance and obviously bilateral enlargement. So let's magnify an ovary, and you can see the pearl string appearance. You can see the cystic areas. They are tiny. They are not. There is no dominant follicle in any ovary, and they are peripherally arranged actually. So this is a case of polycystic ovarian disease. So you can see we have done the measurement. It doesn't matter how you measure, these ovaries are enlarged. So before measurement, you should understand that this ovary is going to be enlarged. So that will guide you for the measurement. So we want to teach our students that you should understand which one is enlarged and which one is not enlarged before doing the measurement. That will make you more superior than the machine. So you're looking at the lever. Oh, this lever is enlarged and before measurement. So there are some tricks over there. So here we can give you a trick that whenever you are having a uterus and transverse section and ovaries are coming towards you, not you are going towards the ovaries. This is the feature of the enlarged ovaries. Okay, then you go for the measurements, however you measure. So both ovaries are more than 10 cc. So these are bilateral enlarged ovaries with polystring appearance and no dominant follicle, echogenic stroma indicating bilateral polycystic ovarian disease. Okay, let's jump into the case number 2. There's a 41-year-old male patient who came for a routine ultrasound checkup. Let's see what we have got on ultrasound. So here you can see the view of the liver. I'm telling the patient to take a deep breath, and you can see that it is quite fatty and the liver is showing mild fatty change, I think. Okay, that's not the topic today. So if you look at the gallbladder, it doesn't look normal. If you look at the fundus, something abnormality is going on here. So is there any calculi or something else? So let's look at the gallbladder from different angle. So we want to see the gallbladder from the intercostal space. Like, let me show you the area where I want to scan. So this is my transducer. So just we are just putting the transducer over here. It's quite like you are getting the view of the kidney and moving your transducer quite medially. You will get the view like this. So this is the long section view, and here it's a very easy view to see the neck of the gallbladder. So if you are suspecting a stone getting impacted at the neck, this is the view for the diagnosis. So anyway, if you look at this view, you can see there are some echogenic areas at the fundal region. This is the fundus of the gallbladder. Okay, so if you look carefully, these are some comet tail artifacts. So there are comet tail artifacts confined just at the fundal region and part of body, not at the neck region. Actually, this region looks quite normal, so only the fundal region is quite affected. There should be some focal wall thickening here, which will cause the comet tail artifact. So this is a case of adenomyomatosis. And in case of adenomyomatosis, if you have gone through the books, you have found a point that hourglass contracture. So this is the hourglass contracture like appearance going on. So we talked about some wall thickening like thing, but it's not quite clear here. So to see the wall thickening better, you easily can use the high frequency ultrasound. So when you are going for the high frequency ultrasound, you can see these are the wall. Let me freeze the image a little bit. Just go here and here. Okay. So look at this picture. You can see this is the wall. And if you look carefully, you can see here is a tiny cystic space. You can see that there's an anechoic tiny cystic space. I'm just looking at the freezed image, and this tiny cystic space within the wall indicates the typical feature of adenomyomatosis. The cystic spaces are quite well visualized when you are using the high frequency ultrasound, not with the regular curvilinear one usually. So this is a case of adenomyomatosis showing focal wall thickenings, casting comet tail artifacts, predominantly involving the fundal region and a part of body. So let's magnify a little again, and you can see the wall thickening, focal wall thickening. Actually, this is not quite focal. It's diffusely thickened at the fundal region, but it's casting cometal artifacts. Now, there is a brother of cometal artifacts. We call it the twinkling artifact. So if you put color Doppler, you will see color comet tail artifact or twinkling artifacts from these areas, which is also the feature of adenomyomatosis. Okay, so the patient had a mild fatty change and the adenomyomatosis of gallbladder. So here's the picture. You can see the comet tail artifacts from the gallbladder wall. So this is a case of adenomyomatosis of gallbladder. This is quite easy case. I think everybody know this one. But now we are going to go for the case number 3. That will be another gallbladder case. Walaikum assalam. I am just looking at the live comments here also. Okay, so welcome to our channel. Anyway, let's jump into the case number 3. That was an interesting case. It was a 67-year-old male patient who came with right hypochondriac pain and fever. So let's see what we have got on ultrasound. Just putting the transducer over the patient's body, we have found mild pleural effusion on the right side. You can see there is no mirror image artifact, and you can see a semilunar anechoic area above the diaphragm, which is the mild pleural effusion. I'm not showing you the mild pleural effusion today, so there will be something else. Now here you can see, I just got confusion here. This is the view of the gallbladder, but I couldn't see any gallbladder. So I asked the patient about any surgical history. There was no scar mark. Patient say that he didn't go for any gallbladder surgery, so the gallbladder should be present. But I was searching like hell crazy, but there was no gallbladder. But the gallbladder fossa was showing this. So is that a duodenum or something else? So you just can rotate the transducer transversely and you can easily separate the duodenum. So we searched for that and we found the duodenum separately. So this structure is not duodenum, rather this one is the gallbladder. So that makes us confused, like which one is the gallbladder? If you look carefully, whenever we are searching for the gallbladder, but the gallbladder is not quite well visualized, we try to search for the gallbladder wall. Now, if you look here, just let me check the internet connection. Okay, it's okay. So if you look here, you can see a thin line over here. This thin line is the gallbladder wall. Now look at this one. Here you can also see some edematous change just adjacent to the gallbladder wall. You can see this hypoechoic thickening here. So the gallbladder wall is probably hypoechoic thickening, showing hypoechoic thickening at this part. So it should be slightly thickened. And okay, so we have got gallbladder wall. Now what are these? You can see some comet-tail-like artifacts, but not from these parts. So if this is adenomyomatosis, okay, I will agree with you. But in case of adenomyomatosis, you should definitely see at least some part of gallbladder wall, but we can't see any gallbladder wall. And usually adenomyomatosis patients do not come with severe acute pain unless there is calculus or something like that. So there should be something abnormality going on here. So here's another picture, and you can see the area of gallbladder showing some comet-tail artifacts, and you can also see some dirty shadows here. Like these are not calculi, but they're casting some shadow-like appearance. So a very important differential diagnosis should be the wall echo shadow sign. So in case of wall echo shadow sign, you see the only the gallbladder wall, then you see some echogenic areas casting posterior-acoustic shadows. So it's very difficult to see the lumen of the gallbladder at that part. So we are also thinking about the gallbladder lumen should be filled with some calculi. If you want to see the calculi of the gallbladder lumen in a case of West sign, you definitely should use the 3D transducer. So we have used the 3D ultrasound here, and with 3D ultrasound, you can see nothing here. Like there is no calculus like thing within the gallbladder from this view. You may ask me about how the West sign looks on 3D ultrasound, right? So let me show you that another case. This is another case. This one is the wall echo shadow sign. Where the gallbladder wall is well visualized, you may not see the lumen or part of the lumen. There are some echogenic areas casting some shadows. So we use the 3D transducer and 3D ultrasound. And on 3D ultrasound, you will see the gallbladder will appear like this. You will see the lumen is filled with some round or oval, something like that. These are the calculi. The lumen is completely filled with calculi. These calculi are not well visualized on grayscale ultrasound, but you can easily see or quite try to see them on the 3D ultrasound. So my case doesn't look like this. It's completely different. So we use the 3D with multiplanar view. We call it the tomographic ultrasound imaging. So we took multiple slices to see at least a view of gallbladder stone or lumen, but there was no stone or lumen. So all the areas are casting dirty shadows and cometial artifacts. So whenever you are getting nothing on 3D, but you are getting cometial artifacts and dark echogenic areas casting dirty shadows within the gallbladder lumen, it definitely should be called the air within the gallbladder lumen. So these are nothing but air within the gallbladder lumen or with some wall thickening. So we call it the emphysematous cholecystitis. So this is a case of emphysematous cholecystitis. Make sure you use the 3D transducer and 3D ultrasound. It's quite easy, and try to exclude wall echo shadow sign, which is a common differential diagnosis. So this is a case of emphysematous cholecystitis. So these are echogenic air within the gallbladder lumen casting some reverberation artifacts known as comet tail or ring down artifacts or whatever you say. So what else we can do? We can go for a CT. A plain CT can easily show you this air within the gallbladder lumen. Okay, now let's jump into the case number 4. So this is a 25-year-old male patient who came with a left hemiscrotal swelling. So this is quite benign case, so don't worry, it won't be very much complicated. So here's the picture. You can see the testes look quite good. This is the right one, this is the left one. You can already see the cause of left hemiscrotal swelling. So you know that I'm not showing you this picture only for the hydrocele, obviously. So there's a mild hydrocele on the right side, and the left one shows a relatively more fluid content. So you'd prefer it as a moderate hydrocele, but I'm not here to show you the hydrocele actually. Let's see the real-time view. So in real time, during the scanning of the left one, we can see there is an echogenic structure within the lumen actually. So you can see this calcified structure because it's casting posteroacoustic shadow. So this mobile calcified structure, if you move the patient, it will move along the posture. So this is just a floating structure, or due to gravity, it has been precipitated. So this calcified structure is known as scrotolith. So scrotolith is a very common feature. Sometimes patient comes with the complaint of pain also. My patient has no pain. He came for only the scrotal swelling. So this is a case of scrotolith. Let's see another one. And you can see this is the epididymis, and this is the fluid within the scrotal sac. A glimpse of testis was also seen. And this echogenic structure casting some shadows is the scrotolith. Now, should I end here? No, obviously no. So this is the scrotolith. It's around 4 millimeter. Okay, now you are getting a scrotolith in your practice, but you can describe it in a different way. You know, we can use 3D ultrasound better when there is a fluid over here. So I always say that if you get a hydrocele, use your 3D transducer and try to take a view of the scrotal of the testis or the scrotal content. So we put a 3D transducer over here, and on 3D you can see this one is the testis, this is the epididymis. You can see epididymis looks quite good, and there is another structure here. This is the scrotolith. So it's quite easy to demonstrate the patient, or it's easy to give a demonstration to the clinician. Just showing this picture. Like this one is the scrotal. He'll be okay. Okay, so we use the multiplanar format of the 3D ultrasound, and we choose this slice, and you can see this one is the scrotal. This type of technique is quite well if you want to see the gallbladder calculus also. Okay, on the right side, there was also a tiny scrotal present. So these are very benign and insignificant usually. So the patient had bilateral scrotal and bilateral hydrocele. Now let's jump into the case number 5. So this will be a young guy. So it's a 1-month-old female patient. Okay, so came with left anterolateral neck lump. Okay, so we are going for the neck region now. Let's see what we have got on ultrasound. So just putting the transducer over the complaint side, you can see there is a cystic lesion here, but this doesn't look quite anechoic. Uh, you can see these are the carotid vessels. So this is the left side, and this lesion lies quite medial and enter to the carotid vessel. So just a medial and slightly superior also. So this is something abnormal, we can understand. Now let's look at the content here, because when you're looking for a lateral neck lesion, there are so many differentials. Now, if you look here, you can see it has got some hazy content inside, like the fluid is quite hazy. And when I touched the transducer, baby was crying. Like a 1-month-old baby won't cry just for some uh, cold gel or something else. So there should be some pain over here. But usually we know that the neck lumps, unless it's the lymphatic origin, or uh, if it is something else like painful, it shouldn't cause any pain. Okay, so this one is painful. Like why it should get painful? Now, if you look at the content, you can see some hazy areas inside. So low level echoes you can see. And you can also see, again, air is disturbing us today. So you can see some echogenic areas casting some dirty shadows here. So we already can say that these echogenic areas are air. So that makes us a little bit careful because we are seeing some air within this cystic area. So let's look at another view. So here you and again can see some solidified area. You can see some air, and the liquid area are showing some low-level echoes within. If you look carefully, you can see the wall of the cystic lesion is quite thickened. So this is actually an infected cystic area, and when you see it on the lateral side or anterolateral side, usually just medial to the carotid vessels, this is actually the bronchial cyst. So this one is an infected or inflamed bronchial cyst. So here you can see this hazy content. So you need to see the extension, how much deeper it can go. And this is a hazy area with thickened irregular wall indicating the inflammatory process going on. So you can see inside air and some hazy content here. So we put the color Doppler, and it showed prominent vascularity on the peripheral aspect. So the lesion measures around 2.7 or 2.8 centimeter in diameter. So this is a case of inflamed or infected branchial cleft cyst at the left anterolateral neck. Okay. Okay, before going to the case number 6, I would like to request you to subscribe our YouTube channel, because it's just nearby to 60K subscribers, and we will upload all our this free contents to our YouTube channel, so you can also get them there. So if you are not connected, you should know that we have already uploaded 465 videos, mostly the ultrasound case videos, here on our YouTube channel. And if you're from the local area, we have a program tomorrow about the hepatoportal Doppler, and we'll add the inferior vena cava also with that. So it will be a big lecture of more than 3 hours. This is a paid session, and this is limited to the local persons because the payment system is quite complicated for the foreigners, and also the language is quite our local language. So many of you have requested to do it for the foreigners, but still we are not satisfied with the payment system. So we better should start with the every Friday free session on our Facebook and YouTube. So, okay, let's jump into the case number 6. Now it will take time. So case 6 to case 10 will be quite larger. So this is a 45-year-old male patient. So he came with a right hemiscrotal painful lump. So we have got 2 scrotal cases today. I have just missed it because I should be careful. I should take 1 case, but unfortunately, or by mistakenly, I have taken 2 topic. Okay. Anyway, so this is a 45-year-old male patient came with right hemiscrotal painful lump with fever. So we thought about any inflammatory process going on. Let's see what we have got on ultrasound. So here you can see the testis. Both testis looks quite normal. Check out the right testis volume. It's around 12 cc. Okay, so we'll show you follow-up pictures of this patient. So there you will see the change of the volume of the testis. So it's around 12 cc. Let's look at the epididymis. So on the right epididymal head, we found 2 tiny cystic structures. Obviously, I'm not showing you this case only for this tiny cystic spaces. So there should be something else going on. So let's see the real-time picture. So here you can see on real time, something is going on. So there is a cystic lesion, hazy cystic lesion with internal septations at the lower end of the testis. The testis look quite normal. So I think this lesion should not be from the testis. If you see this type of lesion, you just need to freeze the image. So let's freeze the image, be a little bit careful, and you can see the lesion is quite away from the testis at this view. Now just go here, you can see a hypoechoic rim here. This hypoechoic rim indicates that the lesion is outside the testis and compressing it. So easily, if you put the transducer transversely, you can easily differentiate it and can diagnose it that this lesion should arise from epididymis. So this should be an epididymal lesion. Okay, anyway, so we have seen that a lesion at the tail region or at the lower end of the testis. We will differentiate it, and you can see some cystic areas at the epididymal head. So let's jump into the lesion quite deeper. You can see the testis looks quite normal, and when we jumped into the lower part, now you can see the lesion is attached to the epididymal tail. So this lesion is of epididymal origin. Epididymis has so many ducts. So whenever you talk about the abscess, it's more common for the epididymis. Whenever you see the ductal dilatation, it's more common for epididymis. Whenever you see the cystic lesions, it's more common for the epididymis. So these things are more common for the ductal lesions, ductal structures. So this is an abscess, I think, because it has a thick-walled, irregular, and with internal low-level echoes. So this should be an abscess. So it's located at the epididymal tail. Now magnify the image and you can see this heterogeneous area with a low-level internal echoes. So this collection at the epididymal tail is the epididymal abscess. So just some views of this epididymal abscess. Obviously, I'm not showing you for just this abscess. We'll show something else also. Okay, so this is the picture of this abscess. So look at the internal content. It's just homogeneous, low-level echoes quite like the endometrioma pattern. Okay, so we'll go for the follow-up. So we'll see the change of this internal content. So we put the color Doppler, and you can see some prominent peripheral vascularity at this area. But we checked that testis, the testicular vascularity was quite normal. So it should arise from the epididymis. So you can see we have decreased the PRF, very low PRF, and the lesion shows no internal vascularity, obviously, and only the peripheral prominent vascular flow. Okay, so the lesion measures around 2.5 centimeter. So this is an epididymal tail abscess. Okay, now what will you do for this patient? So obviously we need to drain this pus. So patient was recommended to go for some drainage of this pus by the surgeon, but the patient refused to go for any surgical or intervention procedure. So now the patient took antibiotics and came to us after 5 days. Now he's complaining about more severe pain, and the fever continues. Even he's not allowing me to touch the testis or scrotum right now. So it's very painful, and the skin is more edematous right now. So here's the picture after 5 days. Now you can see this abscess. It looks quite enlarged, more compressing the testes. Cysts are also present. But if you look at the internal content, it looks more solidified here, but some fluid contents are also seen. So here's the abscess right now. You can see the solidified portion and the fluid content here. The skin is more thickened here. The scrotal skin looks thickened and edematous. So we think we need to use color Doppler now. So on color Doppler, you can see definitely the abscess cavity doesn't show any flow, but the overall testicular vascularity looks quite increased. So the testis is nearby to this structure, so it will definitely get inflamed. So that is what's happening now. So this is the epididymal tail abscess of this patient. And I have told you that you should remember the right testis volume. It was 12 cc at the first scan. Now it's around 16.5 cc. So it got enlarged and it is more round right now. So which is the feature of enlargement of testis. So we put the color Doppler, and the testicular vascularity has slightly increased now. So the inflammation has extended up to the testis. So this is the abscess right now, and the skin is quite thickened in comparison to the left one. Okay, so is that okay? The patient was again told by the surgeon to drain the pus, but the patient refused again. So now he has changed the antibiotic. These are happening by himself or someone else. Now he came after 7 days again. So now the pain has increased more and the fever continues. Let's see what we have got on ultrasound. So here's the picture right now. So the testicular volume is quite shrunken. I don't know why. So maybe my mistake or something, but the testis looks quite irregular, which is a very important feature because it is going to get some necrosis inside because the inflammation is progressing. So you can see the scrotal skin is quite thickened. You can see some inflammatory collection, which was not seen on previous scans. And the epididymis doesn't look quite good. So we need to look here. So we put the color Doppler as usual. The testis shows very high vascularity and the epididymis also, but you can see some depression over here, which was not present at previous scan. So it indicates that our testis is getting softer. So it's not getting hard, rather it's getting softer. So it is getting compressed by even epididymis, which has no power. So the epididymis shows multiple areas where you can't see any flow within. So let's see on real time. So this is the testis, it looked dead. So here you can see the abscess, but you can also see similar type of structures throughout the epididymis, which was not present before. So these are the abscess also involving throughout the epididymis. So patient was told that if you don't drain the pus, you may need to go for orchidectomy. So he waited, and now it's a quite easy indication for orchidectomy or just cutting down. So this is the abscess, which has more solidified nature right now, but the inflammation and abscess progressed throughout the epididymis. So you need to remove all of this right now. So here again, you can see the abscess fluids throughout the epididymis. So this is the extension of the abscess right now. So this is the extension of the abscess cavities throughout the epididymis. So we put the color Doppler, and you can see there is no vascularity in these parts. So these are the necrotic portions. And obviously the testis is the next organ, which is going to get necrosed. So this is a case of right epididymal abscess along with its consequences. So it's easy to finish with a one-line sentence, but when we had to describe a lot. So let's jump into the case number 7. So we are at the end, I think, just 45 minutes. So this is a 64-year-old male patient who came with a lump at the back of the knee, left knee. Let's see what we have got on ultrasound. So here on the left knee at the popliteal fossa, you can see a mass here. It's easy. It's a hypoechoic mass. This is a common site where you see the Becker cyst. So this is not a Becker cyst. It doesn't look like a Becker cyst. Oh, there is a finding over here. So if you have watched my previous video, you have seen similar type of case with some difference. So you can see the popliteal vessels here, but this lesion is not attached to the popliteal vessel. But if you look carefully, just freeze the image at the appropriate time and just freeze here. You can see there is a tapered end here. This is the important feature because the lesion has a central cystic area, which is actually a necrotic area. So whenever you see a mass with internal necrosis, you think about so many differentials. But whenever you see this tapered ends, the diagnosis gets limited. So this is the tapered end. Let's look at the other side's tapering. You see, this is the tapered end here. And if you look at the other part, just look carefully, just look it carefully. I think I have this one. This is the tapered end over here. So this is a round or oval lesion with internal cystic area of necrosis and tapered ends. Okay, so let's take the another image, and you can see this is the tapering of the superior end, and this is the inferior end, and the lesion lies at the popliteal fossa. So let's look at another view, and here it's a little bit magnified to see the internal content. We try to see the lesion showing some vascularity within this cystic space so that we can make a diagnosis like some aneurysm with thrombosis or something like that, but it's not like that. So we put the color Doppler, and you can see there is no vascularity within the lumen. Rather, you can see the vascularity within solid part. So it is not a venous or arterial aneurysm. Rather, it's a solid mass with tapered end, predominantly peripheral vascularity, and internal necrosis. So here's the color Doppler, and you can see the vascularity again. So let's put some power Doppler. So here's the power Doppler, and again you can see the predominantly peripheral vascularity, not very severe vascularity actually. So whenever you see a lesion with this type of round or oval hypoechoic appearance, with or without necrosis. Necrosis is quite uncommon because this patient is 67-year-old, so necrosis may happen. And if you see there is a tapered end over the upper and lower part. So you should think about nerve sheath tumor, peripheral nerve sheath tumor. And this is the area for the tibial nerve passing. So you see this lesion is attached to the tibial nerve. This is that area for the tibial nerve. So this is a peripheral nerve sheath tumor of tibial nerve origin. So here you can see there's the lesion, and on color Doppler you can see some vascularity. So the resistive index is 0.75. Okay, it's not a very high vascularity like any malignant lesion. So this is the peripheral nerve sheath tumor of the tibial nerve at the left popliteal fossa. So you need to know the nerve anatomy for every peripheral nerve sheath tumor. Okay, so let's jump into the case number 8. We'll call it sonoma with our histopaths. Okay, so there are so many things that can happen. So better for imaging, we will, especially for ultrasound, we'll try to stay with the nerve sheath tumor, I think. It varies from the center to center, how you report it, but we usually try to stop ourselves at peripheral nerve sheath tumor. Okay, so sonoma is the most common, I think. On histopath, we usually get that. Okay, so let's jump into the case number 8. So this is a 61-year-old female patient. It's also the right lateral neck lumps. I think I have made another mistake to take 2 cases of neck lesions, but this one is Doppler case, so it's quite different. So let's see the thyroid. It looks quite normal. This is a cross section of the thyroid gland. This is the isthmus, this is the right lobe, and this is the left lobe. Not a good picture. So these are the measurements of the thyroid gland, which also look quite normal. So this is the right lobe and left lobe on long sections. It looks quite normal. So there's nothing going on here. So now look at the area from different view. So this patient was sent to us for the thyroid gland ultrasound as well as the carotid system evaluation. So the carotid vessels were quite normal. Just there was some atherosclerotic change or something like that. But you can see something going on here. If you look here, this is the common carotid artery, and this is the internal jugular vein. It doesn't look anechoic. You can see some heterogeneous contents inside. So you can see some focal dilatation also. So this heterogeneously echogenic, slightly echogenic content within this internal jugular vein is nothing but the thrombus. So this is a chronic thrombus. Usually if you see hypoechoic to anechoic thrombus, this is acute, and if it is more echogenic, it's just a chronic thrombus. So this is a chronic thrombus within the internal jugular vein. Let's see on different view. So we try to press a little bit and it's not compressible, and you can see there is no flow within the internal jugular vein. You can see flow within the common carotid artery. So internal jugular vein thrombosis. Is it okay? No, it's not okay. Why there is thrombus within the internal jugular vein? There should be something else present here. So you need to search for them. So this is the internal jugular vein thrombus. It's a big thrombus within this whole length of internal jugular vein at the distal part. Okay, so let's look elsewhere. You can see this. Is this a lymph node? No, 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 no. It's a branching nature. So it's not a lymph node. This is the external jugular vein. You see that this is the area for the external jugular vein, slightly laterally. And it also is showing some thrombus within. So it's also echogenic thrombus. So this is a chronic thrombus within the external jugular vein also. So now the question arises, why the hell the external jugular vein showing thrombus in this patient? So both the internal and external jugular vein, there was no procedure done for this patient. So it's very unusual to have thrombosis. So there should be something else going on. So you can see this is also that thrombus within the external jugular vein. So you can see the thrombus on long section also. So why is the thrombus here? So here's the picture. You can see the panoramic shot where you can see the thrombus within the external jugular vein. Now, it took our attention. We need to search for something that can cause this type of lesion. We can't go inside the chest. I didn't have any sector or phased area transducer. With linear transducer, I can go a little. But when I was trying to search for the supraclavicular region, I can see something. This is the thrombus. Okay, this is the common carotid artery, but I have seen something else. So you can see some hypoechoic areas. Okay, so is that a methylation or something else? So here you can see a hypoechoic lesion. This is the area for the supraclavicular lymph node actually. So these are actually enlarged lymph nodes at the right side. Okay, but the lymph nodes doesn't look quite normal. You can see the lesions are quite hypoechoic. There is no hilar echoes present. So it may be due to the tuberculosis, which is very common here in our country. Like patient comes with tubercular lymphadenitis or lymph node necrosis, and it's quite easy. But usually, whenever we see the tubercular lymph node, they don't usually compress the adjacent blood vessels. I don't usually see the patient coming with thrombosis and some lymph nodes. It's uncommon for tuberculosis. So it is more common for malignant lesions like for metastasis or for lymphoma. It's quite common. So we need to exclude them. There is no history of any primary tumor. Patient just came with some lumps at the right side of the neck. So I need to search for them as a primary or first investigation right now. So here you can see the lymph node, right, supraclavicular one, which is more adjacent to the jugular vein, and it's quite round, heterogeneously hypoechoic, doesn't look quite good. And if you see its vascularity, it doesn't show very prominent internal vascularity. So it took our attention. So let's look here. You can see the thrombus in the internal jugular vein, and you can see the large lymph node here, which is the supraclavicular lymph node, and also some other lymph nodes of similar nature or similar ecotexture nearby. So you can see the thrombus within the internal jugular vein, which is now not very important feature for me. I just want to know why these notorious lymph nodes are here, because you can see some surrounding fat planes are also thickened. Let me freeze the image. You can see the echogenic thickening of the fat layer. So it should be something abnormal. So put the color Doppler and you can see the prominent peripheral vascularity, but the central areas show no prominent vascularity. Okay, so how can you differentiate whether it's a malignant lesion or it's an inflammatory lesion? Usually can take the spectral Doppler, and spectral Doppler may guide you further. We are not going for any intervention right now, so we just want to close it with the color Doppler. So let's put some color Doppler here. So on color Doppler, you can see the hilar vessel, which is quite here, you can see. So it's showing some vascular flow, and we took the sample. You can see a arterial wave pattern here, and we tried to measure the resistive index. It's around 0.75. Okay, so if it was an inflammatory lesion, the diastolic flow should be quite more. And usually we get less than 0.7 of resistive index for the inflammatory lesions. It's quite very common. So it should not be considered as an inflammatory lesion right now. So it should be something else. So we want to differentiate between the metastasis and the lymphoma. Make sure whenever you get the resistive index of a lymph node in between 0.7 and 0.8, you should first think about the lymphoma. If it is more than 0.8, it should be thought as metastasis. This is not accurate measurement tool, but it will give you a very good decision-making issue. So this patient was diagnosed as a case of lymphoma. Okay, so we had no idea about lymphoma for this patient. We just started, we solved some thrombosis. Okay, fine. We just gone through the scan. We found some lymph nodes, but the resistive index was unusually increased at a range of in between 0 0.7 and 0 0.8. So we thought that it may be a lymphoma case. In case of metastasis, the hilar artery gets compressed, so the resistance go high. So we thought that this might be a lymphoma. So we asked the clinician about the situation, and the patient was gone through CT scan or any more scanning techniques, and then for the histopathological evaluation or any biochemical, whatever you do. So the clinician noted that this is a lesion from lymphoma. Okay, so there was more mediastinal lymph nodes and so many things that I forgot. Just saw them on the CT, and clinician just noted that this was a case of lymphoma. Okay, so this is a case of a right internal and external jugular venous thrombosis with right cervical lymphadenopathy, which was later diagnosed as lymphoma. So make sure whenever you get two things, just think of two important points for this case. If you get jugular venous thrombosis, it should not be the only feature for this patient. You should search for something at the distal part of the internal jugular or external jugular veins. So it might be some mass lesion there, or superior vena cava obstruction or something else. So you need to search for them. Okay, so you can do a CT or something else. But if you find the lymph node, you should be very careful. And if you find any lymph node which has a resistive index more than 7, you should be very careful that this is not an inflammatory case. You should differentiate from metastasis and lymphoma. And usually the metastasis has a resistive index of more than 0.8, and lymphoma has a range in between 0.7 and 0.8. Make sure this is not an accurate information, but it will guide you. Okay. So let's jump into the case number 9. So there's a 3-year-old male patient who came with bilateral painful swelling over the parotid regions and with a history of fever. So this will be an easy case, no complications, because the case number 10 will be very long. So we'll try to make it easy. So we have got 60 plus participants today. So if you think these videos are helpful for you, please don't hesitate to share them, because this will actually help other people to know about some cases, because many parts of the world has no good facility for the clinical practice or clinical exposure for the beginners. So we have been requested by many participants of our YouTube project to make some live contents. That's why we made them. We usually do 3 classes, that is online classes for our local students. And but you people got angry that I'm not taking any session for the foreign people. I told you that it's very difficult for me to demonstrate in foreign language for 3 hours. So we just ended it as some case demonstration, and hopefully for every week, if you get 10 cases like this, it will be beneficial if you're a beginner. And if you're an expert, your presence is highly valuable for us. So let's jump into the case number 9. Let's see what we have got on real time. So here you can see the picture of the thyroid gland of this patient. So this is a baby of 3-year-old. So everything looks quite normal. This is the submandibular glands, which also look quite normal. So let's jump into the parotid glands. Now here on parotid system, here you can see it doesn't look normal. So both sides parotid glands look heterogeneous. You can see some hypoechoic areas throughout the parenchyma. So this hypoechoic, are they lymph nodes? No, these are not lymph nodes. So many lymph nodes can be present here. But this hypoechoic pattern throughout the parotid gland indicates that there is something abnormality going on, which we want to see on real time. Here you can see the right parotid gland, and you can see some cheetah-like appearance. So you know the cheetah tiger. You can see some hypoechoic nodule-like appearance within the parotid gland. This is a very important feature of the acute parotitis. So in children with fever and lump-like feeling, this is usually due to mumps. Right now, you are looking at a case of mumps. Okay, so on I haven't adjusted it. So on color Doppler, there was a slight increased vascularity, but due to the unusual adjustment, the vascularity is not well understandable. But still, the parenchyma showed a good amount of vascularity. It's not very much necessary for all the patients to show high vascularity in mumps. It depends on the level of treatment. It depends on the day of inflammation patient came to you. So don't be crazy about the Doppler findings. So here is the left parotid gland, and you can see it's also showing similar nature, hypoechoic spaces within the left parotid gland, indicating the parotitis. So in the view, you can see some lymph nodes here also. These are quite common feature because there is some inflammation going on here. So put the color Doppler. Now we have adjusted a little, and you can see the vascularity. And the parenchyma is showing very good amount of vascularity with 1.3 kilohertz PRF. You usually won't see any flow within the parenchyma, but here you can see them. So this is a case of acute parotitis. So this type of hypoechoic spaces throughout the parenchyma is also known as pomegranate sign. So do you like pomegranate? So this is the pomegranate sign. Okay, so this is a case of bilateral acute parotitis. So let's jump into the case number 10. This will be an obstetric case. So we haven't shown you any obstetric case, so you may get angry. So we have chosen a case of obstetrics, and hopefully you will like it. So this is a 19-year-old female patient who came with amenorrhea for 8 months. So this is not a good time for anomaly scan, but the patient was sent because he has a very bad history of coming to the doctors. So I think this is the first time she managed to come to the doctor, and the doctor sent to us for an ultrasound scan. Let's see what we have got on ultrasound. So here you can see the picture. You can see the fetal face in coronal section. You can see already there is the oligohydramnios. Now, what you can see here, you can see this is the eyeball, and this is the skull vault. Okay, so the vault is absent. You can't see anything above the orbit. So this is the brain matter over here, and you can also see there is no nose here, like a nasal bone is absent. We'll see it on different view. So from this view, you can see a frog-like appearance of the face. This is the coronal cut of the face, and you can see both eyeballs. So overall, from this view, we have seen the cranial vault absent, which is the feature of anencephaly. But as there is a brain matter over the head present, so you can call it exencephaly. So if I end it here, it won't be accurate one. Why? If you look at the picture, this is an exencephaly. Okay, I don't have any complaint about that. This is true. But we know that in anencephaly or exencephaly, we commonly get a good amount of amniotic fluid, like patient comes with polyhydramnios, but we can see some oligohydramnios here. So we are not satisfied. We need to search for something else. Now the baby can't move quite well, but we need to see the head should move quite well. So let's see another view. So here we have changed the transducer direction. You can see we can see the fetal hand. Okay, I have no complaint about that. But I am looking at the margin of the brain. So here you can see in case of exencephaly, it's at for 34 weeks old baby. So it doesn't look like a 34 weeks old. It looks like something like 2024 something else. So there should be a growth retardation here. And in between this time, in case of exencephaly, the brain matter should get dissolved, like it's getting eroded by the uterine wall, and it will get dissolved within the amniotic fluid. So amniotic fluid should look more hazy, but it's not present here. So I can see whole of the brain parenchyma, which is already deformed, uh, but there is absence of cranial vault. So now you look carefully, the whole brain or this part of the brain is attached to the uterine wall, even attached to the placenta here. So that took our attention. Let's look at another view. So here we have tried to put the long section, or you may call sagittal section, and you can still see the brain matter is not separated by any way from the uterine wall. So this is attached to the uterine wall, which took our very big attention. And this is a case of body stalk anomaly, which is causing the exencephaly in this patient. So before going to another picture, if you look carefully, this is the area of the cerebellum, and it is also deformed. And you can see there is no cisterna magnum here. Rather, you can see a triangular structure entering into the upper part of the cervical canal, which is the caudal herniation of the cerebellar tonsil. So, which is common feature in Cherry 2 malformation, I think. So again, another problem here. So let's look at another view. And you can see the brain is attached here to the placenta and uterine wall. So this is called the body stalk anomaly. This is a lethal condition. You can't deliver these babies, okay? So this is a lethal condition, and the prognosis is obviously 100% more mortality. You want to deliver without brain? Okay, now let's look at the facial region right now. So it's a very difficult situation for me to show you the facial abnormalities, but if you just freeze the image a little, let's freeze the image. Let's look carefully. Just move the transducer a little, and I think it's not very easy to demonstrate that there is a cleft lip present here. So let me show the still picture where you can see it. Okay, so yeah, here is a view of the cleft lip. I think it's not very good picture. So this was the gap. It's not very good, easily demonstrable. Okay, so this is this is the part. Just let me show you here. You can see it is attached to the placenta here. So this is the body stalk anomaly, which is a rare case, I think. So it is attached to the placenta and the brain matter. So whenever you see the anencephaly, you should not end it with the anencephaly only. You should see the brain matter. You should see the attachment of the brain matter. Sometimes it may get attached with an amniotic band only, or it may get attached to the uterine wall like here. So you need to differentiate, or you need to confirm it more. So here you can see it is the brain matter which is attached to the uterine wall, also the placenta, which is called the body stalk anomaly. And there was no nasal bone in this patient. And also there was a cleft lip. I think it's not very easy to demonstrate actually. So you may skip that thing. Okay, so it was quite confusing at the first time. So here you can see this is the femoral length, which shows, I think, 26 weeks of gestation. It doesn't match with the last menstrual period history. So definitely there is a growth restriction also. Don't ask me to measure the middle cerebral artery in this patient. It will be difficult for me. So here you can see the brain attached with the placenta and amniotic layer. Okay, so it is the attachment with the high frequency. You can easily see it is attached to the uterine wall. So just see the attachment due to the body stock anomaly. So let's jump into the other parts of this baby. So I told you that we need to go a little more further. So here you can see, let me freeze the image a little. So here you can see this is the tonsillar herniation of the cerebellum into the upper cervical area. So this is the feature of cherry 2 malformation. So whenever you think about cherry 2 malformation, you definitely should search for the spinal abnormality also. So we try to search for the spine. It's a disgusting image. Okay, here you can see some dysraphism here, I think. Yeah, freeze the image here. Just go a little backward. You can see these are the segments of the vertebra. You see, it is attached here. So it's not segmented. So something abnormality going on here. So there is a scoliosis here also. So this is the spinal dysraphism at this part. This is the uh, upper dorsal vertebra, which is showing some spinal dysraphism. You know, it took a long time to end this case, actually, when the patient came to my chamber. Okay, so this is the caudal herniation of the cerebellar tonsil. And this is the spinal defect. If you look carefully, there is a hemivertebra over here. Usually when you see the spine is getting broken like this, there is a scoliosis here. So there should be some hemivertebra present there, or a blocked vertebra, whatever. Let's go a little further. So here is the foot. You can see the tibia fibula. And whenever you see the tibia fibula attached to a 5-finger view of the foot, it should be called club foot. It's easy. Like if I show you my hand, you can't see, like think about this is my foot. This is the 5-finger view. You can't see any tibia fibula here. But if my hand is, or my foot is just rotated like this, now you can see attached tibia fibula here. So this is the principle, like when the foot is in a normal position, you should not see the attached tibia fibula from the 5-finger view. But if you can see them, it indicates there is a club foot present. So we can see tibia fibula and there's the 5-finger view. So the leg is showing the feature of club foot. So here's the club foot. Only the one leg could be understandable. So clubfoot is present. Now let's look at the abdomen. So here's the liver, which is very enlarged, and you can see some intestinal loops. This thing is not urinary bladder, this is the gallbladder. So it is also showing a thickened wall, which usually comes with ascites. And here you can see some ascitic fluid collection. The picture may not look quite good. My machine is not very bad, but there is no amniotic fluid. The fluid is very low, so it's making some disturbance. So this is the ascites along with hepatomegaly and thickened gallbladder wall. What more? So this is the liver, which is quite enlarged, 6.4 centimeter from any different angle. Anyway, so the chest was also slightly narrowed in comparison to the abdomen. The abdomen is slightly distended or the chest is slightly narrowed. So it may be due to the hypoplastic lungs or something else, but the views are not quite well, so we don't want to go for them. So the baby was female, and you can see the labia here. So there's a female fetus. We usually don't do the gender determination in our chamber. It is restricted, but you have no idea about this patient, and the patient has no idea about the gender. So I can show you. So this is the labia. So this is a female baby. So let's make the report. So there are multiple and obviously lethal fetal anomalies present in this case. So the body stock anomaly, which is causing the exencephaly. There is cerebellar tonsillar caudal herniation along with some hemivertebra and obviously scoliosis. And there was nasal hypoplasia, cleft lip and cleft palate, which is not well demonstrated here because I forgot to take the video of that part. And obviously, there was a suspicion of pulmonary hypoplasia because the chest is quite narrow in this patient. And there was a hepatomegaly with thick-walled gallbladder with huge ascites, and there was a club foot also. So all these features are present. So ultimately, the prognosis is very bad. So thank you for joining me for this long session, and hopefully these cases will be helpful for you. Many of you are connected from very far away from my country. So it's a big honor for me actually. So if you are not connected to our YouTube channel, we have a YouTube channel named Imaging Study, which will just get, I think, 60K plus subscribers within this week, and we'll upload this video to our YouTube channel. So if you want to repeat, or you can also check our previous contents here in this YouTube channel. So don't forget to subscribe and try to share it with your friends if you think these videos are helpful for you. And we'll also have a free content of a similar type of case demonstration on 20th December. The time schedule is given here. So the Great Britain time is 2:30 p.m. So you can just calculate it with your time. So you can just join us on your suitable moment. So these videos will be uploaded to our YouTube channel also. So you can also go there if you are not available for the live session. So if you're a local person, we also have a paid content on the hepatoportal Doppler ultrasound. We'll include inferior vena cava, which we didn't include in previous sessions. So this time we'll include it here. We'll include the aorta on the renal class. So just to decrease the number of the class, and this will be helpful for the local persons. So if you are not the local person, I'm very grateful for you because you have joined me. But the payment system is quite complicated, and we have no refund option for the foreign people. So we have closed it. And also, this is on the local language, so it won't be suitable for the foreigners actually. And for foreigners, we are arranging free contents for in every week, every Friday at this class schedule time. So you will just try to join us on our Facebook page. So you can get our informations and class schedules on our imagingstudy.com website. And also we have uploaded few cases there, but we are not quite regular. We should be regular, but we are not regular with our website. I don't know why. Okay, so thank you for joining me. I hope this will be helpful, and hope to see you on your next session. So if you have any question, you can just ask me on our Facebook Live. I have only a few persons connected because nobody knows about these sessions. So if you think these videos are helpful, just try to share this content or our schedule to your friends. Some of your friends may need these videos, okay? Welcome, welcome. Rather, I would like to thank you all for joining me. Okay. Okay, so we try to search for 10 important cases from our regular practice every week and try to arrange them for demonstration in this program. So if you're free, you please try to join us on the Friday, 2:30 p.m. Great Britain time. So calculate for your country time, and hope to see you on our next session on next Friday, I think 20th December. Until then, thank you. Thank you for joining, and see you there. Have a nice week.